Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid and our today's topic of discussion is aortic dissection, a very high yield topic for USMLE step 1 and step 2 preparation. Okay, now we'll start with the definition. What is aortic dissection? So aortic dissection, it is a longitudinal intimal tear forming a false lumen. Usually the big vessels in our body has three layers: intima, media and adventitia. So aortic dissection is an intimal tear, a tear in the intima of the vessel that forms a false lumen. Okay, and then that blood propagates down towards it. So usually aortic dissection seen in the patients around the age of 40 to 60 years and more common in males than in females. Now, what is the definition of aortic dissection? I've told you a longitudinal intimal tear forming a false lumen is aortic dissection. Now, what would be the patient's presentation? Usually, patient presented in the ER with the tearing chest pain that radiates that radiates to the back, towards the back, in between the scapula. So, a patient will present in the ER with a tearing chest pain that radiates towards the back, with or without unequal blood pressure or pulses in the arms. This is the usual presentation of patients in the ER with aortic dissection. Now, what are the risk factors of aortic dissection? What are the conditions that increases the risk of patients having aortic dissection? Always remember, the single most important risk factor is hypertension. They have asked question. I have seen this question. The what is the single most important risk factor for patients with aortic dissection is hypertension. There are other risk factors, but always remember hypertension. What are the other risk factors other than hypertension? So bicuspid aortic valve, mitral valve prolapse, inherited connective tissue diseases like Marfan syndrome, and chest trauma. These are all the risk factors for aortic dissection, but always remember hypertension. Usually, the patients of aortic dissection are hypertensive. If the patient is presented in the ER with classical chest pain of aortic dissection but is hypotensive, then consider cardiac tamponade or hypovolemia from the blood loss. Okay. So there is an example: a patient presented in the ER with a tearing chest pain that radiates towards the back, and you have taken the history, you did the physical examination, and you checked the pulses and blood pressure that both our pulses and blood pressure are unequal in the arms. Then you did the chest X-ray, and in the chest X-ray, what is the classical finding we will see in the chest X-ray of patients with aortic dissection? It is going to be mediastinal widening. The widened mediastinum on the chest X-ray is a classic finding of aortic dissection. Look at this image A. This is the CT angiography of the chest that is showing aortic dissection in the ascending aorta and the dissection in the descending aorta. Okay, so we did the history, we did the physical examination, we did a chest X-ray and widened mediastinum. Okay, now what is the best initial test to diagnose aortic dissection? This is again a UL question where they asked about the best initial test to diagnose aortic dissection. So, in hemodynamically stable patients, the best initial test is CT angiogram of the chest. Okay, if the patients are hemodynamically unstable, then we will do transesophageal echocardiogram (TEE). For hemodynamically stable patients, CT angiogram is the best initial. For hemodynamically unstable patients, TEE. Okay, and if the contrast is contraindicated, then we can do MR angiogram instead of CT angiogram. Okay. Now, what would be the findings we see in patients? Tearing chest pain radiating towards the back, unequal pulses or asymmetric pulses, and blood pressure. Um, Patient can have a murmur of AR, aortic regurgitation murmur, if the aortic valve is involved. Okay, if the dissection progresses proximally towards the aortic valve, then we can see AR murmur as well. There can be neurologic deficits if the spinal arteries are involved. There can be anuria if the renal arteries are involved. Okay, so now let's talk about the types of aortic dissection. So there are two classifications. The first is Stanford classification, and the second is DeBakey classification. So let's talk about Stanford classification first. Stanford classification divides aortic dissection into type A and type B. From type A, always remember, if there is an involvement of ascending aorta, no matter if descending aorta is involved or not. If there is an involvement of ascending aorta with or without involvement of descending aorta, it is going to be type A. For type A ascending dissection, ascending aorta should always be involved. Okay, if there is no involvement of ascending aorta, then it is type B, um, type B Stanford aortic dissection. Okay, so and then there is another classification, DeBakey classification, which divides aortic dissection into three types: type 1, 2, and 3. Type 1, when there is involvement of ascending aorta and descending aorta both. Type 2, when there is only involvement of ascending aorta. And type 3, when there is only involvement of descending aorta and no ascending aorta. So for type A, ascending aorta is always involved. Type B, ascending aorta is not involved. Okay, now let's talk about the treatment. First and most important treatment is to control the heart rate and blood pressure, because if the heart rate and blood pressure would remain high, um, it increases the severity of dissection. So first and most important is to control blood pressure and heart rate. And we control blood pressure and heart rate with the beta blockers. The first line treatment for aortic dissection is going to be beta blockers. And the best example is asmolol. This is a UL question. The first line treatment of aortic dissection is asmolol, a beta blocker. Okay. Now for type A, after giving beta blockers, we will go for emergency surgery, because type A aortic dissection, they are more severe. They have a more risk. They have a high mortality risk. So we go directly for, first we'll give beta blockers and we'll go for the surgery. For type B, if there is an evidence of ischemia, yes, then we'll go for the urgent surgery after giving beta blockers. If there is no evidence of ischemia, then we will continue our medical management with beta blockers. Okay. Here is a high yield flowchart I wanted to share with you guys. I hope this is gonna help you people. So if you're suspecting aortic dissection, initial evaluation would be history, physical exam, labs, ECG, chest X-ray, suggestive of aortic dissection. Chest X-ray will show widened mediastinum. Yes, we will go for other diagnostic imaging. The first line for hemodynamically stable patients is CT angiogram. If contrast is contraindicated, then MR angiogram. For hemodynamically unstable patients, transesophageal echogram TEE. Okay, if the CT angiogram or TEE shows aortic dissection, then we will control heart rate and blood pressure with beta blockers. The example is esmolol. For type A, after beta blocker, we'll go for emergency surgery. For type B, if there is evidence of ischemia, yes, we'll go for urgent surgery. If no, we will continue medical management. Okay, so this is all about aortic dissection. If you guys have any questions, you can ask me in the comment sections. Thank you so much.